My name is Sara Prokup, and I work at the Shirley AbilityLab with Dr. Jayaraman in his lab. I've worked with him for about 10 years as a physical therapist and now the clinical manager as well. So today I'm going to be discussing what impact neurological injury has on gait, the principles of neuroplasticity and why they are important to consider when developing a gait training program, strategies for how to structure and progress a gait training program, selecting objective outcome measures to guide the gait training intervention, and finally, a summary of clinical implications and key takeaways. So there are many types of neurological injury that we see in the rehabilitation setting, as you all know. Some of the more prevalent diagnoses we see include spinal cord injury, stroke, brain injury, multiple sclerosis, and Parkinson's disease. So generally, these types of injuries can cause impairments in patient abilities related to motor control, muscle strength, sensation, and balance, and all of these things can lead to gait impairments in these populations. The impact of these gait impairments can extend far beyond mobility alone. These changes can significantly restrict an individual's participation in home and community environments due to risk of further injury, fear of falling, and overall reduction in independence. Over time, these can lead to decreased activity levels and greater sedentary behavior, ultimately increasing the risk for long-term health consequences, including cardiovascular decline. So, knowing that the impairments from neurological conditions can have a significant impact on an individual's gait, how can you intervene effectively? To address the deficits, you first want to structure a very targeted and highly specific rehabilitation program. So one principle that helps clinicians to build and guide these structured programs is the FITT, or FIT principle. Each element within the structure is modifiable to personalize treatment to each patient, and it helps to structure the session for most efficient delivery of exercise. So a starting place to help determine what parameters to use for this, you can look at frameworks, established resources such as the American College of Sports Medicine Guidelines for Physical Activity, and that says to include moderate intensity of aerobic physical activity for a minimum of 30 minutes on 5 days per week, or vigorous intensity aerobic activity for a minimum of 20 minutes on 3 days per week. So this FIT principle provides a structural framework for guiding an exercise program. But to truly drive recovery, we must also understand the mechanisms that support neurological adaptation. So neuroplasticity is the nervous system's ability to change its structure, function, and connections in response to experience, learning, or injury. When looking at the 10 principles of experience-dependent neuroplasticity from Clem and Jones in 2008, 3 factors are especially important in neurological recovery following neurological injury. Those 3 are specificity, repetition, and intensity. So, in order to improve at a particular task, you need to practice that task. For example, pre-gait activities such as weight shifting or standing balance are not necessarily shown to improve walking specifically. Walking training improves walking and also simultaneously trains things like weight bearing, stepping, and balance. Walking is a continuous task, and therefore you don't need to practice each element within it separately. So to improve walking, you want to practice walking. The literature shows that repetition is also an important variable needed to enhance motor learning. Large amounts of task-specific practice to learn or relearn a motor skill is considered to be a critical variable to enhance plastic changes in the brain. So several studies have found that working on gait training can actually translate to improvements in some lower level tasks, such as transfers and standing balance. So therefore, you can spend more time focusing on the complex task of walking rather than splitting your time between various low-level tasks. Intensity can be defined as work per unit time or effort level, or the cardiovascular demand that's placed on the patient. It can be manipulated by either increasing speed or increasing the amount of force or resistance applied to a certain task. Many studies indicate that patients will demonstrate greater improvements in cardiovascular fitness and walking performance following high intensity training compared to low intensity training or conventional therapy. So as you're targeting to achieve high intensities of training, it's important to measure a heart rate response to exercise, not only for the safety reasons, but also to ensure that you're targeting the appropriate training intensity zone to maximize your output of your gait training session. So to determine target training zone, what you want to do is use either the age-predicted heart rate max formula or the heart rate reserve formula. So target heart rate is then calculated as a percentage of the heart rate max or heart rate reserve. For high intensity training, you want to target 70 to 85% of the heart rate max or 60 to 80% of the heart rate reserve. For patients who are taking certain medications like beta blockers, we tend to see a blunted heart rate response to exercise. So therefore, for patients who are on beta blockers, you want to subtract about 15 beats per minute from both your upper and lower ranges of your target heart rate zone to account for this. In some patients, we do see that using the heart rate max or heart rate reserve formula might not be a reliable method to track their intensity. This could be due to various physiological reasons such as atrial fibrillation or other medications that the patient may be taking. In these cases, you can use the Borg rating of perceived exertion scale. This is a useful alternative, and it's a very subjective measure of how hard somebody is exerting themselves. It's administered by having the patient choose a number on this scale, and this will correspond to how hard or how much effort the patient is exerting. It's not going to show how difficult the task feels from a balance or coordination standpoint, but you want to ask the patient how much effort it's causing them to put forth in the task. We want to measure the cardiovascular demand and not the task complexity. For walking training at moderate to high intensities, we want to target 14 to 17 on this scale, which goes from somewhat hard to very hard. One limitation, though, with this scale is that it does rely on accurate self-reporting, which can be challenging when you're working with patients who have a cognitive impairment or if they have difficulty understanding the scale. So using target heart rate and Borg RPE as a guide, variations in intensity can be achieved by manipulating or changing speed and force. So in this video of a patient walking over ground, we can see some examples of how the therapist is able to progress this. So initially, the patient starts out walking with a quad cane and an AFO in a body weight support system. Then you can see that the therapist has removed the assistive device, and she's also lowered the body weight support in addition to adding some resistance around his affected limb. So those all increase the load through his legs that he's receiving during the therapy. Here she's doing some lateral stepping with him, so she's changing up the task that he's doing, and also some backward stepping, so increasing the challenge to the patient, therefore increasing the intensity. So you can also see she has the red heart rate monitor on his gait belt, so that, or on his harness, so that she can make sure that he's in his target heart rate zone the entire time that he's working. So here she's actually physically pulling the patient forward to try to increase the speed of his walking. And by doing that, she's increasing his intensity. You can also use stair climbing during gait training to increase intensity, so the patient's having to take a much larger step and put a lot more force through their legs as they're stepping up those stairs. So when you're working with patients and doing gait training, you can do this through several different modalities. So you can use just the regular overground training, which can provide a very highly task-specific exercise, and it encourages the patient to adapt to challenges in a real-world situation. So you saw that patient kind of stumble a little bit, and then he was able to adapt and react to that loss of balance. Bodyweight supported treadmill training is a way that patients can achieve a high amount of repetition and stepping practice, and then they can also manipulate things like speed and incline and load and intensity through the controls of the treadmill. And you can also use robotic exoskeletons for gait training as well. So this will help the patient achieve a high repetition of stepping, but it also provides external support to posture and joints as the patient needs it. So this can help a patient who maybe needs a little bit more assistance than you could provide either overground or on the treadmill. So to ensure you're having a successful gait training session, you want to make sure that you're achieving 4 different subcomponents of gait. And the first one of these is propulsion. So propulsion is the ability to move your center of mass in a specific direction, whether that's forward or backward or sideways during stance. The second one is limb advancement. So this is achieving adequate foot clearance during swing, and then also achieving a positive step length on both sides. The third one is postural stability, and this is your ability to maintain upright in both the sagittal and frontal planes and keeping your center of mass within your base of support. And then the fourth one is stance control, and so this is not allowing either your trunk or your leg to collapse during stance. So all of these components can be achieved with or without therapist assistance. And as you're looking at each component individually, you can either assist or progress the patient depending on their ability and their ability to successfully achieve each component of this biomechanical subcomponents of gait. So for propulsion, this is again the component that is responsible for forward momentum. This is largely driven by the effective push-off of your trailing limb. But when this is impaired, we can initially support forward momentum by reducing load or assisting forward translation. So as the patient's ability to achieve this improves, you can then shift your focus to progressively increasing the demand by removing assistance and adding speed, incline, or resistance. And you will then be challenging force production and drive more powerful, efficient forward progression. So limb advancement is the ability to clear and swing the leg forward when taking a step. When this is impaired, you can initially support this movement through use of orthotics, hands-on assistance to help with the swing phase, or you could add body weight support, and this is going to reduce the amount that the patient's going to have to use their muscular strength to get their leg forward. So then as the patient progresses and their control and their strength improve, you can progressively challenge them by increasing any demand of the task. So you can add resistance using ankle weights like we saw in the previous video. You can add elastic bands to add resistance, or you can introduce things like obstacles, which is going to cause the patient to have to use a little bit more hip flexion, a little bit more dorsiflexion to get their leg to actually progress into a forward step length. So again, postural stability is the ability to maintain your center of mass over your base of support while you're walking. And the main purpose of this is so that you can avoid a fall. So when a patient's stability is limited, you can provide hands-on assistance to help with this. Body weight support, again, which is going to lift the patient up, take some weight off their legs, and give them a little bit more stability that way. You can add additional strapping. So like if somebody's on a treadmill, you can add different straps that can give them a little bit more support to keep them upright. Or you can use assistive devices like we saw in the video as well, and that's going to create a safer and more controlled environment. So as the patient does improve with their balance and motor control, you can then progressively reduce that external support and increase the challenge and the variability of the training. So examples of that would be reducing the upper extremity support, incorporating different directions of walking, so multi-directional stepping like lateral or backward stepping, adding dynamic tasks like agility ladder drills, obstacle negotiation, balance beams, or walking on uneven surfaces. And then the final component here, stance control. So that's the ability to accept weight through the limb during stance without having the limb collapse. This applies to the trunk as well. So when this is impaired, you can initially provide hands-on assistance like you would with a manual knee block in stance from the therapist, or you can use body weight support to again lift the patient up, and then they don't have to overcome as much force to keep that knee straight. As their strength and their alignment and their confidence all improve, you can generally start to reduce that external support and increase the demand again. So this could include limiting the upper extremity support or progressing their assistive device. You know, you can go from a more supportive device like a walker to something like a cane or even no device at all. Again, you can add resistance, whether that's ankle weights or elastic bands, and you can incorporate higher level tasks like obstacle negotiation, uneven surfaces, or stair climbing. So kind of a theme there with either providing the assistance through manual support or additional external supports, and then progressing using things like resistance and variation in the way that you're training the patient. So to put it all together, this is a video that's going to show an example of how these assistance strategies that I just went over can help for a patient that's ambulating on the treadmill. So in this first video here on the left, you can see that this patient, he's walking without the use of any kind of additional strapping other than the harness that he's using for body weight support. And he doesn't seem to really have enough body weight support, so he's kind of collapsing as he's walking. He's kind of swinging back and forth in the harness, and he's really leaning towards his left side. So all of these things are kind of causing him to be very unsuccessful with getting his left limb forward, and also getting the knee straight on the left side, so having that stance control and that postural control, even though the therapist is helping him. So the therapist is putting forth a lot of effort, and we're not really seeing anything that's the most efficient way to train here. So in the second video right here, the therapist has changed a few things. So for one, what she's done is she's added a little bit of body weight support, so lifting him up a little bit more. In the back, there's a strap. It's a posterior pelvic strap, so that red strap that's going behind the patient, and it's connected to the two handrails of the treadmill. And then there's a lateral strap as well that's on his right side that's kind of pulling him over into more of a right weight shift. So all of these things are kind of helping him to become more stable. He has improved midline positioning, and you can see that he's actually clearing his left limb a lot better than he is in the first video. And then the therapist is able to give him that knee block, and he's getting full extension on that knee during stance phase. So those were kind of strategies to use to help assist a patient if they're not able to achieve those biomechanical subcomponents of gait. Now I'm going to show you ways to progress, and so if a patient is kind of improving in their ability to achieve those things, you can progress them and make the challenge a little bit harder. So here you can see the patient. He's walking on the treadmill. He's using the harness for safety mostly, maybe a little bit of body weight support, and he was holding on to the handrail. So here, the therapist has asked him to let go of the handrail, and you can see this is challenging his balance a little bit, but he's still able to recover. So it's allowing him to make kind of a small error that he's able to correct, that he'll be able to gain some motor learning from. Here, the therapists are adding obstacles on the treadmill so that he's having to take a little bit longer step, so he's achieving that positive step length. And then he's also having to kind of react in real time to something that would be a little bit more similar to like if you were walking down the street and maybe a kid kicked a soccer ball or something in front of you. You have to react kind of quickly. So similar to that. So introducing variability into gait training, it's also shown to produce greater improvements than just forward stepping alone. So there's a couple different ways that you can introduce variability into your gait training. One example is kinematic variability. So allowing some errors in the kinematics to improve motor learning. And we saw that in the last video. So when we took away the patient's upper extremity support from the treadmill, he kind of wavered a little bit in his balance, but he was able to recover. And the more that he practices that, he'll come up with strategies to be able to recover, during any type of loss of balance. You can also introduce types of environmental variability. So this would include walking on different terrains, indoor versus outdoor. You can add a little bit of dual tasking. So maybe having the patient walk while you're asking them either to name foods from A to Z or name countries that start with, B, or having somebody maybe count backwards from 100 by sevens. So just adding that cognitive task to the motor task that they're doing of walking. You can also have people walking on uneven surfaces or doing stairs, a lot of the examples that you've seen in the videos so far. Another way that you can introduce variability is to add random practice. And this is something that's going to help reinforce learning pathways and task retention at more varied times and contexts as compared to just constant blocked practice. So all of these things can introduce variability into your gait training sessions and really increase the challenge to the patient as well. So here's a video that's going to demonstrate some of those strategies here. So you can see the patient here is already starting off with doing some multi-directional stepping. He's doing a little bit of lateral, a little bit of backwards. Therapist also has some resistance on his ankles, increasing the challenge that way. Here he's working in the agility ladder. So he's having to kind of piece together a sequence. So that's adding a little bit of a cognitive task, as well as he's stepping kind of in and out laterally. So, using that multi-directional stepping again. Here's kind of a double task as well. So he's not only doing obstacles, but he's also doing that with lateral stepping. So kind of a double challenge for him there. And then here, instead of just keeping on with doing lateral, 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 they've changed to forward walking and then doing lateral. She's kind of mixing up the order of everything. So he's kind of having to adapt to each situation differently and uniquely, so that that increase in variability is going to make it harder for the patient, and they're going to learn more strategies on how to react to these changes in the environment and changes in obstacles and things like that. So as you're gait training with your patient, we talked about high intensity, so you want to make sure that you're also keeping the session safe for the patient. So as you're training, again, using something like a heart rate monitor like this one here, or there's tons of different heart rate monitors that you can use, or even checking manually to not only ensure that they're in their target heart rate zone, but you also want to identify any signs or symptoms that may be in the abnormal range. So sometimes as you're working your patients very hard, you do have to distinguish, is it an actual abnormal sign, or is it that you're just really challenging them and they're becoming fatigued? So it's important to kind of distinguish between those. But if you do see abnormal signs and symptoms, it's always good to keep ongoing communication with the physician and the medical team so that you can kind of change up the therapy and adapt the program and modify, and then that way you're not you're not going to be compromising overall safety in any way. So working with patients, a lot of these principles that I was just talking about, those can be applied to a lot of different neurological disorders. But it's also it's important to consider the patient's diagnosis and if there are any unique characteristics that may affect the structure of the gait training program. So I'm going to talk about two diagnoses here. So Parkinson's disease and multiple sclerosis, which are both more progressive diseases, whereas stroke and brain injury and spinal cord injury, those are a lot of times more of a sudden onset. So there's kind of a difference there. And then in the way that the diagnoses present themselves, so you may have to make a few modifications to your program based on that. So in Parkinson's disease, you mostly see a slowed velocity, a decreased cadence, shortened stride length. Sometimes you see freezing of gait, and often there's a lot of postural instabilities. So recent literature is going to tell you that amplitude-specific training programs are highly beneficial for individuals with PD. So there's a specific protocol of these standardized whole body sustained and multi-directional movements with feedback regarding how big the movement is. And that type of training is termed LSVT big training. And that's something that's used quite commonly for patients who have Parkinson's disease. So for example, having the patient take a nice big step, and you're really emphasizing those larger amplitude movements with these patients. They may also benefit from auditory cueing and rhythmic auditory stimulation strategies. And those types of strategies can include using music, counting, or walking to the beat of a metronome. So for individuals who have MS, fatigue is a very major symptom seen in the majority of these patients. So they have a higher energy cost as they're walking, and higher resting heart rates with endurance testing. So walking and cardiovascular fitness is still very important in this population, but due to the increased energy cost for their movement and higher fatigue levels, you want to consider maybe a less intense range of walking activities. So now you can target a slightly lower Borg score or a slightly lower heart rate max range or heart rate reserve range, and you're kind of targeting more of that moderate intensity for these patients. So with all of these strategies that I just described, how can we be sure that we're affecting change for these patients? So using objective outcome measures can help identify changes from baseline, and then it can also inform you on how to adapt your training program to specific areas. So many of the outcome measures that I have listed here have been shown to have strong reliability, validity, and predictive value for fall risk. So each of these outcome measures also measures a different outcome from your gait. So for example, 10-meter walk test is going to measure your gait speed, whereas 6-minute walk test is going to measure more of the patient's endurance. The Berg balance scale and functional gait assessment are going to be measures of either standing balance or dynamic standing balance. The timed up and go is going to be a measure of functional mobility and balance. And you can also use questionnaires in addition to the physical outcome measures to see how your patient's doing. So things like the ABC scale, which is listed here at the bottom, that's a scale that you can use to ask your patient how confident they feel with their balance in doing certain everyday tasks, so like walking up the stairs or doing a crosswalk, something like that. So it's very applicable to real life, and you can kind of get a sense of what the patient is feeling too as you're asking them these questions. So to create a successful gait training program for your patient with a neurological injury, you want to focus on specificity, intensity, and repetition, as well as integrating the FIT principle. You want to use target heart rate zones to successfully achieve moderate and high intensity training while you're also ensuring the patient's safety. So you want to also either assist or progress your patient to successfully achieve propulsion, limb advancement, postural stability, and stance control during gait. And you want to consider anything that may be unique to the patient diagnosis that might affect the intensity that you're using or the type of training that you're using. And then you can also use objective outcome measures to identify goal areas and ensure you're affecting change for these patients. So in summary, here's an example of a comprehensive gait training program which considers a lot of the principles that I covered here today. You want to focus on continuous stepping at a high dosage, including elements of variability at moderate to high intensity, using varied types of gait training depending on the goals of your session. So thank you very much for having me here today. I appreciate the opportunity.
Thanks a lot, Dr. Sara, for walking us through the gait assessment and training. And any questions, please?
Ma'am, have you talked about the Parkinson and adult? For a pediatric population, are you using any harnessing system in pediatric strokes?
Yeah, I guess it depends on kind of the severity of the patient's diagnosis. So whether or not they're able to get up and be able to achieve those components of gait or not. So for the higher level patients who have a little bit more walking ability, I probably wouldn't be using that harnessing system. I'd probably mainly be using it just for maybe like a safety catch, just to add additional safety and stability. If there's a clinic that doesn't have those overhead harnesses, things like gait belts, those things can, provide enough support, or just providing some sort of an assistive device to the patient, like a U-walker that can help provide that support without having them be at risk for falling.
Do you think cognitive ability is mandatory for persons working with these type of patients?
Do I think that cognitive ability? Yeah, absolutely. 100%. Yeah. So I think you do have to consider the patient's cognitive level of function as well as their physical level of function, because as you're trying to use some of these principles, things like I think I mentioned the board rating scale of perceived exertion. Somebody who has a severe cognitive impairment is not going to understand what you're asking them, and you're not going to get an accurate reporting level. Sometimes two patients may have difficulty with that dual task. So you kind of have to, gauge where your patient is on the spectrum of, low cognitive function to high cognitive function, and also low mobility to high mobility, to determine which of those tasks you're able to do with them and how you're going to progress them in that sequence.
Could you share you have any objective measurement for pediatric gait?
Objective measures for pediatric gait. Yeah. So I know a lot of pediatrics is not my specialty, but I have seen a couple of outcome measures that are used in that population. I do know the GMFM, so the gross motor function measure, is a big one that's being used for gait in that population. You can also use the 6-minute walk test and the 10-meter walk test in children as well, or pretty much any population. Those are very common outcome measures that can be widespread in their use across all diagnoses.
Okay, thank you.
Thank you.
Sara, it was very good. My question is, the first part of your topic, one video, it showed like you were talking about the speed of the patient's gait. Like the therapist was actually literally making him walk very fast. So my question is, usually what we do here, like what I like to do is working on speed only after correcting the gait pattern. Because what happens when we work on speed without a proper pattern is the patient learns compensatory techniques, and then after some time they will not progress much. We'll have to again relearn and learn, unlearn and relearn. So my question is, will that be a better choice, or you feel that the working on the speed early enough itself is good? Because I've been practicing the other way, like.
Yeah, that's a really good question, because we're seeing gait impairments in pretty much every patient that we work with, right? So if we're continually focusing on just those impairments first, and we're striving for perfection, we may not ever get to that point of perfection, and then we're not able to progress our patients past that into increasing the speed like that. So again, it's kind of a balance. You have to determine, is it really the kinematics that you're after, or is it that getting the patient into this target heart rate zone so that they can then see some effects to those impairments from the high intensity? Is that something that's going to be more beneficial to the patient than if they walk with a perfectly beautiful gait? So it's that balance. Yeah, you can use cycling, and I'm not saying that the only thing you can do is walking. It's just looking at specificity. If you do want to practice walking, or you want walking to improve, you do want to do a high amount of that practice. But you can complement that therapy with other types of cardiovascular exercise, like cycling, or anything else. You want to incorporate some strength training as well. And it also is important to practice things, like transfers and standing balance and all that for patients maybe at the kind of initial stage of their injury as well, because they do need to get around in their home and their community too. But kind of from the presentation to those high amounts of walking, they have seen in the literature, there have been studies that have cited that they do see improvements in those areas from practicing the high intensity walking as well. But yeah, great question.
So how does gait training priorities difference between say a stroke, spinal cord injury, and brain injury, even if the outward gait deficits are similar? And how do you incorporate error augmentation versus error correction? At which part?
Mm-hmm. Yeah, so the question is kind of what's the difference in how you're going to structure it between each diagnosis?
Each even different neurological conditions, but the deficits are the same. The outward deficits are the same. And how do you incorporate the error augmentation versus error correction? At which part? Is it the early stages of?
Yeah, so early stage, I'll answer that one first. So early stage, you're going to see patients are kind of needing more assistance, more support. So you want to maybe have them have less error as they're working. So initially, patients are going to just need to get that repetition in, and you want to help support them, help give them that knee block so that they're achieving kind of not errorless completely, but you want to have them on the lower end of errors. It's not going to do them any good. They're not going to kind of learn from making those errors. But as the patient kind of progresses along the way, you can start having them work where they're doing a task that's allowing them to make some errors. So like we saw the guy on the treadmill, he was a little bit higher level. He was able to make some of those errors with his balance, and he's able to correct it. So kind of determining where on the spectrum your patient lies, and are they able to make that correction if you give them an error, or are they just kind of at the start and you just want to get them up and moving and working on that intensity. And then your question about the different diagnoses. So I think the principles that I was talking about, those can be applied to kind of all different diagnoses. I think in terms of, having like a specific brain injury program or a stroke program or a spinal cord injury program, there are unique characteristics that apply to all those populations. But I think too that everybody in those, all across the board, all those patients can benefit from the high intensity training and just getting them up and walking as much as possible so that you're seeing changes not only in the walking function, but also in those other tasks, like transfers and balance and those types of things.
Thank you.